Hey guys, this is Dr. Paul Thomas, and you might have seen the JAMA article about direct primary care yesterday. It was released yesterday. So I read the article, and one of my medical student colleagues sent me a few questions about it. He said, "I'm curious to hear your thoughts on the assertion in the article that DPCs may contribute to the growing shortage of primary care physicians for especially Medicaid patients. Do you think that's a fair assertion?" And I would say no, absolutely not. That is not a fair assertion, because what's the alternative? If you get burned out on fee-for-service medicine, which is a hot buzzword right now, physicians are getting burned out, they're leaving the practice of medicine, they're pursuing other things, then you're removing a physician completely from the system. Versus the alternative, that physician may be going from 3,000 patients to only 500 or 600 patients in DPC. They're still in the system, they're still seeing patients, they're still practicing medicine, and perhaps they're even inspiring other young doctors to pursue family medicine or internal medicine or pediatrics or med peds, where they could be a DPC doctor. Frankly, we need more primary care physicians, and we need more primary care physicians to come alive and be the doctors that they're meant to be. And I feel like direct primary care allows physicians to do that. So I really think that's unfair to say that, oh, you're taking physicians out of the system. I would argue that you're allowing doctors to stay in the system to continue to be doctors. The next question they asked was, this doctor in the article was mentioned as going down from 6,000 to 600 patients, and they were noted to be making the same amount of money in both scenarios, and that seems suspect to this student questioner, because you have to have a certain number of patients. What's brilliant about the direct primary care model is that you're only billing $50 a month, $70 a month, $90 a month, $10 a month for kids. That's roughly what I charge in my practice, and that's roughly what a lot of doctors across the country charge. So in that way, if you have 500 members at $50 a month, that's $25,000 in revenue each month, minus maybe $10,000 a month in overhead, puts you at about $15,000 in income per month. And that can be on par with what doctors are making in the fee-for-service world. So I can't speak to everyone. I'll probably come out making perhaps about the same or maybe a little bit less than if I was in the traditional system, but I'm seeing less patients, I'm more healthy mentally, I'm not burnt out. So I think it's a fair trade-off, and I think it's a fair comparison between making the same amount in the traditional practice with 6,000 and then with 600 in the direct primary care model. And then this questioner's most looming concern about the practice of DPC is taking care of patients who are Medicaid or low income. How do you reconcile billing people $50 a month who are low income? And so my assertion is that I do see a lot of Medicaid patients who are in my practice because they want to be treated like a human. They want to be taken care of in a clean, safe, kind, welcoming environment. And that's the sort of environment that I can provide. Even though I'm just in a one-room office, it's just me, but I can also provide that higher level of care, and I can do it in a way that's socially conscious and equitable. So I really believe in direct primary care's ability to take care of people at all income levels to be able to deliver a really high quality service. All right, thank you so much for watching, and have a great day.